Next, it gives me a great pleasure to introduce Professor Chris Bundy, who's now based in Cardiff. She's Professor of Behavioural Medicine and Health Psychology and Honorary Professor in Manchester. She told me an interesting fact yesterday, actually, that her daughter is a 400-metre Olympian who was in Rio. I think we were regretting our lack of fitness together. But she researches and applies psychological interventions for patients with long-term conditions. Chris works quite closely with us in our joint psoriasis clinic with Professor of Rheumatology. And we really look forward to your talk today. Thank you.
Thank you. Thank you very much for the invitation to come and talk. And I'm particularly honoured as a psychologist to be amongst so many eminent dermatologists. And I have to say I really enjoy working with dermatologists, so I'm pleased to be here. So we're going to change tack a little bit and talk about mindfulness. It's something that's very much in the popular press. It's very much in the psychological literature, and it's just starting to come through into dermatology as a potential intervention. So watch this space. So we're going to really have a look at why mindfulness may be relevant to patients living with psoriasis, and particularly those with complex psoriasis. So we'll have a look at the stress model, if you like, the stress paradigm. We'll have a look at what mindfulness is and maybe what it isn't. I'll give you some information on whether it works, looking at the comparison with other psychological interventions and indeed other interventions. And then I guess we'll have a look at does it have a place in the management of psoriasis? If we have time, we'll do a little bit of mindfulness just to finish off the session, but we'll see how it goes. Okay, so just to remind you that stress can't easily be reduced to events that happen to us and the way that we respond to them. It's very much about the individual's interpretation of that event. That's what matters. So the response, stress is the response that occurs when one weighs the disadvantages of a stressful event, whether it's moving house, moving professional location, whether it's a divorce, whether it's an illness, with the capacity that we as individuals have to manage that demand. So it's the cost-benefit analysis that we do when we experience stressful events. So the key point, the really important thing, is that it's about the individual's perception of that event. And that helps to explain individual differences, so why two people exposed to the same events might respond in very different ways. So this slide illustrates some of the demands that patients are living with, patients with psoriasis. They have the current comorbidities that they may be living with: inflammatory bowel disease, psoriatic arthritis, cardiometabolic disorder. The psychological distress that's well documented in the literature now, particularly around anxiety, depression, the features around illness beliefs and treatment beliefs which weigh heavily on people's capacity to cope. The current background inflammation has a very direct systemic effect on mood. We mustn't forget there's a connection between brain and body. They're not separate entities. They use shared pathways. And, of course, patients are very concerned about the future risk, potential and actual future risk of these comorbidities, and indeed about the treatments the patients are using. All of this is weighing quite heavily on their ability to manage the demand. There's two ways in which we can we can approach the management of these stressful events. We can either approach it as a problem and deal with it effectively as a problem, or indeed we can use emotion-focused coping, which is to avoid the problem. That's what we see quite a lot of the time with patients, that they tend to avoid or put off managing to stay lean, managing to stay fit by comfort eating, and they put on weight. And we were hearing this morning about the importance of weight gain, adipose tissue, particularly in the central region, as a risk factor for cardiovascular disease later on, and indeed for more psoriasis. So patients are doing this cost-benefit weighing in terms of the stressful events on a very regular basis. So just to remind you, you'll be very familiar with some of the pathways that are already fairly well documented now. But again, I just want to draw your attention to the threat perception. It's the individual's perception of events that happen can stimulate pro-inflammatory cytokines, pro-inflammatory mechanisms, and indeed the double whammy of immunosuppressing hormones. And this slide just gives you the complexity, which all of you are very familiar with. You know, this is not news to you. But maybe what is news to you is the fact that some of the psychological factors can impact on these hormonal cascades in exactly the same way as the background inflammation does. In psoriasis and stress, we also have the additional neuroendocrine activity producing melatonin and creating itch and further exacerbating symptoms of psoriasis. So we've got some very plausible and very clearly demarcated pathways that link beliefs, thoughts, and mood, how people feel, directly with psoriasis. So what we have are these mechanisms. They're not very clearly, they're not very, there aren't any high quality experimental studies that are showing these pathways, but at the state of the art is such, and the state of the science is that we have very plausible pathways, we have good animal models demonstrating this, but in psoriasis we don't have the high quality studies yet. However, what we do have is an acknowledgement that acute stress and chronic stress works in slightly different ways. Acute stress prepares us for the fight-flight response, fight-flight, or indeed the freeze response, which we now realize is a third aspect of fight and flight. But chronic stress leads to overstimulation of the hypothalamic pituitary adrenal axis. And this leads us over time to become both less responsive to stress, the acute stress mechanisms, which are effective and adaptive, and it leads to less cortisol secretion or responsivity. So we become blunted to these stress responses over time. So we know that stress is a major issue. This is the potential pathway from the perception of the stress stimuli, people's beliefs about it, their cognitive processes, how they interpret that belief, leads to an assessment of do they have the capacity to deal with this threat, which leads to reduced circulating or at least interrupted circulating cortisol, overstimulation of the HPA axis, increased sympathetic nervous system arousal, which leads to that whole cascade, higher levels of pro-inflammatory cytokines, overproduction of skin cells, and of course, therefore, the end point, more psoriasis symptoms or more severe psoriasis symptoms in susceptible individuals. Now, what's really interesting and something I'm quite fascinated by is why an individual on a particular occasion may not feel the brute force of stressful responses, while on another occasion they might. So what makes what makes intra-individual differences with how they respond to stress stimuli? So how might mindfulness as a practice and as a different kind of technique, how might it influence these processes? We need to look at the different forms of altered state of consciousness. So we know that, for example, meditation, hypnosis, and mindfulness share some similar features, but are also quite distinctly different in some ways. So just to remind you that hypnosis is a form of strategic self-deception in the sense that we periodically fool ourselves into believing that we're in an altered state. It involves having focused, executive intentions whilst seemingly being unaware of these intentions. So there's a kind of paradox within hypnosis where we appear not to be in control, but actually we are in control. We've bought into a belief that someone else is helping us to do something that we perhaps didn't want to do. So it implies a kind of suspended or an absence of mindfulness. So in a way, it's kind of diametrically opposed to hypnosis, but it shares some of the features. Meditation, on the other hand, is an established Buddhist practice which involves and cultivates mindfulness, a state of mindfulness. It involves being aware of the mental state that we're in, coupled with focused higher order thoughts. This is described as metacognition. This is knowing what we're thinking, knowing our patterns, and knowing that we can step back from those processes and manage them in a different way. Mindfulness, following on from meditation, is an acute sensory state of very focused awareness. It involves an open channel of communication, a connectedness with our senses and with our surroundings. And it also encourages us to accept the experiences that we are experiencing and to focus on being rather than doing. And I'll come back to that difference between being and doing towards the end of the presentation. So there are 5 facets of mindfulness that we need to be aware of. John Kabat-Zinn has done most of the work in this area, following on from Eastern Buddhist philosophy and practice and bringing it into a more Western approach and applying it in psoriasis and in other long-term conditions. But he talks about 5 facets: observation of our internal and external sensations, being aware of them, drawing our attention, focusing our attention on some of these sensations. Being aware of the present moment, not thinking about what we didn't do yesterday and what we have yet to do tomorrow. Being in the here and now is a clear and important prerequisite for good mindfulness practice. Being able to label our experiences, so knowing what we're thinking, knowing what we're feeling, and knowing how we're behaving. Those 3 components make up our psychology. Being able to give them names and to differentiate states is a key aspect of mindfulness. Being non-judgmental of our experiences. So if we're aware of thoughts, intrusive thoughts that come into our mind, something we might have said over dinner yesterday to a loved one that we wish we hadn't said, something that we're planning to do tomorrow that we know is going to be stressful, but not judging those experiences, just welcoming them as experiences. And then finally, being non-reactive. So what that means is allowing these thoughts to come and go without responding. So just being in the moment, recognizing that we're having these experiences, not being distracted by them, and not worrying about them. So training in mindfulness aims for participants to find these alternative experiences and perspectives on their experiences. And in particular, to put aside preoccupations, to recognize there's a pattern emerging within their preoccupations. That's to be dealt with later, but the mindfulness in the moment is recognizing our own patterns. And in particular, some of these stress patterns, because you all get into a groove, we get into very specific ways of thinking about stress, and this always actually determines our response. So if we label something as stressful, we will respond in a stressful way. So it aims to accept and to potentially change, but that's for later in the process, ways of processing information. And it was really interesting being in the psychodermatology session yesterday, where we looked at some fMRI images of people's altered information processing in real time. That was quite exciting to see that the brain is clearly responding to events, whether we're aware of it or not. Okay, so is there any evidence that mindfulness, psychological interventions in general, are effective at managing or at least attenuating some of the aspects of dermatology? Well, given the prevalence the known prevalence of distress in dermatology patients, particularly psoriasis patients, and the potential role of attention and interpretive bias that we were talking about and thinking about yesterday in maintaining negative mood states, interventions to reduce this attentional bias should be beneficial. So when there's a plausible platform, a theoretical rationale for why mindfulness should be effective in changing individual attentional bias. But what we find in the literature is very small effect sizes from any interventions that focus around mindfulness. The effect size is there, but they're small, and that's largely as a function of the poor sample sizes and the lack of controls that we have in many of these studies. Unfortunately, we don't have high-quality scientific studies in this area that we can say unequivocally mindfulness is an effective intervention. But there is some hope, and we have got some rationale for designing these high-quality studies. We know that mindfulness reduces psoriasis symptoms. We know that it's helpful in managing anxiety. We know that it helps to reduce the impact of shame. And we know that it changes rumination. It stops people focusing and thinking about the negative aspects of living with psoriasis. And it helps to increase self-compassion. And what that means is people stop judging themselves harshly, and they start to see themselves as a recipient of life events and psoriasis stressors that happen to them, and they stop judging it and judging themselves so harshly. However, the evidence in terms of sympathetic nervous system arousal, the way that we mark and measure stress, the evidence is not there. So what mechanisms are working in terms of managing psoriasis symptoms, reducing anxiety and so on, these cognitive changes? We can't really identify that pathway, that link through the physiological pathways. So we need well-controlled studies to be able to look at this in more detail. So what actually does mindfulness do then? Well, it helps to concentrate and channel attention. And you are all highly successful people. You're able to do this, to channel your attention and your focus in terms of passing exams and functioning on a daily basis with colleagues and with patients. But out there in the real world, many people struggle to focus their attention. Attention deficit disorder is much more widespread than we are aware of amongst professional groups. And people have all sorts of ways of managing their attention. But we do know that when we're able to channel attention, this increases neuronal connections. It makes stronger and more widespread neuronal connections, linking with previous memories and therefore linking with other effective coping mechanisms. It helps to shift this focus away from the individual, the self-referent, to connectedness with physical surroundings, and in particular with sensory experiences. And I keep coming back to this because at the end of the session I'll tell you why that's relevant. So it allows us to be more perceptual and less conceptual. So we start to feel rather than do. We start to be less focused on what we have to do and more focused on being in the moment. It allows us to decenter, and this is this metacognitive state that I'm talking about. Once we step back from how we currently experience ourselves and become curious about why did I respond in that way? What was I thinking? How was I feeling? Once we manage to take a look at those patterns, we can then start to interrupt them if they're dysfunctional patterns. So it gives us a heightened reaction and a better recognition of these personal reactions and patterns. When people get stuck with an unhelpful way of coping, they're stuck in a pattern, a circle that they find it hard to get out of. So my job as a psychologist is to help them to be a sounding board, to point out their patterns so that they can interrupt them. The key thing is both skill-based and a mindset. It's an attitude and a skill. So we can learn the skill. If we want to play the Moonlight Sonata, we have to do the scales. There's no shortcut. So it requires teaching, but more importantly, it requires practice. We can teach ourselves, but we do have to practice. So how does mindfulness compare with other therapies, other forms of therapies? Well, you will be very familiar with pharmacological therapies, anti-anxiolytics, antidepressants. By and large, for the majority of patients who are not clinically depressed or severely depressed or severely anxious, these treatments are not very effective. But we do know that cognitive change therapies are effective for people with psoriasis who have a reaction to living with psoriasis, who react with distress. So arousal reduction techniques are another form of treatment intervention that works on a physiological feedback system. So cognitive changes focus on thought processes and feelings and how those two interact, and arousal reduction techniques work very much on physiological sympathetic nervous system arousal reduction. How do they compare? Well, I've already said that pharmacological therapy is not very effective. In fact, there's hardly any evidence that pharmacological therapy is effective for this patient group. But what we do have is those that focus on cognitive change, thought process change, either through emotional disclosure, writing down how you feel, telling someone how you feel, or indeed looking at these links between thoughts, feelings, and behavior, and the direct stress reduction through hypnosis and progressive muscular relaxation. So that's the kind of differentiation between the different kinds of interventions. Which one's effective? All the evidence points to CBT. Cognitive behavior therapy does have a good evidence base. Emotional disclosure has a very poor evidence base. There's a moderate evidence base for hypnosis and progressive muscular relaxation, particularly in combination. But the most effective form of therapy is CBT. So, what do we know about CBT? It can reduce symptoms of psoriasis and associated anxiety and depression, distress. There's no doubt about that. There's a good systematic review which has just come out concluding just that. It's an effective form of therapy for the management of psoriasis. It helps in terms of psoriasis area and severity reduction. Systemic treatment, in addition to CBT, doesn't further enhance the effects of CBT, which is interesting. And the effect of psychological intervention is stronger on patients with moderate to severe psoriasis than patients with mild to moderate psoriasis. So there's some interesting findings that really warrant further good systematic probing and scientific investigation. So which therapy for which patients? Obviously, maybe it's less obvious to you, but certainly obvious to me, given that I've talked about the individual differences in stress response, we need a personalized approach. Blanket approaches to psychological therapies in the way that blanket approaches to psoriasis management are not effective. We need tailored approaches. We need good assessment of the individual in front of us to know which psychological intervention to choose for that individual. We know that some people need more than one kind of intervention. So we might want some sympathetic nervous system alteration through progressive muscular relaxation or hypnosis in conjunction with CBT approaches. We know that anxiety blocks many of these therapeutic approaches. So if the patient is not yet ready to work on cognitive thought processes, maybe they are ready to work with relaxation or hypnosis or mindfulness. Or conversely, maybe they're just unable to relax physically, but they can address some of their thought patterns. So it's about a careful assessment that's important. So to conclude, the reports of stress remain consistently high in psoriasis. We can't avoid this any longer. We need to be addressing the nearly 40% of patients who are clinically anxious or clinically depressed in your clinics. Stress has both a direct and an indirect effect on self-management. We know that. It's preventing people from being effective self-managers. It has a direct relationship with non-adherence that we continue to ignore at our peril. Mindfulness appears to be an effective treatment, certainly at some level for alleviating distress, but the mechanisms of action are not quite clear yet. There are no reports of harm in using mindfulness, but some people are less responsive. which really brings me on to the last thing that I just want to tell you about, really, which is how to assess for susceptibility. So we know that some people are less responsive and some people are more responsive. So how do we work that out? Well, some people are more attuned to their surroundings, to their sensory input, but we can help to channel their attention towards being more receptive to environmental cues. So if we, do we have any time at all left? How many minutes? 2, 3? Couple of minutes left. So for the next 3 minutes, I just want to help you to test your susceptibility. So if you'll bear with me and close your eyes. It's quite important to close your eyes because you need to focus on the sound of my voice. Not that it's difficult in this room, but... Okay, so I just want you, in your mind's eye, to picture yourself in your kitchen at home. Okay? So in your mind's eye, have a look around. What can you see in your kitchen? Can you feel the texture of the surface, the work surface, whether that's smooth or warm or cold? I want you to reach into a drawer in the kitchen, in your home, and select a very sharp, serrated knife. You feel the steel. You pull the knife out of the drawer. You go to your work surface and you choose from a fruit bowl in front of you a lemon. Beautiful, bright, yellow lemon. You see the texture of the lemon, that slightly raised, waxy, knobbly texture. You place it on a chopping board and you cut in with a serrated knife. You cut through, all the way through to the lemon so that it falls neatly into 2 balanced halves. You smell the zest, that tangy, wonderful, fresh zest of the lemon. I want you to pick up half of the lemon. You feel the texture again of the outside of the lemon. You also feel the juice of the lemon running through your fingers. You pick the lemon up and you place it near your mouth. You can smell that intense lemon smell. I want you to open your mouth and squeeze the lemon into your mouth and taste the lemon drops. Okay, so put your lemon away, open your eyes. You're back in the hall, you're no longer in your home. I just want you to reflect on which of the senses you were able to connect with most easily. Was it the smell? Was it the taste? Was it the texture? Was it the surroundings in your kitchen? Were you able to feel the work surface? Were you able to look around and see where everything's placed? That will give you some indication of which sensory modality is dominant for you. We all have dominant modalities, and that one will give you some indication of your preferred sensory modality. Now, what I would be doing in mindfulness sessions is capitalizing on that and getting you to focus your thinking and your feeling within that dominant sensory modality, but also expanding your ability to work with the other senses. And so if you were able to taste, smell, touch, feel any of those examples that I gave you, then that gives you an indication of how susceptible you are, both to hypnotic suggestion, but more importantly, to working with mindfulness. So if you were genuinely unable to feel, smell, touch, see, or any of those things, you need to do some work. Failing that, those of you who could, then you're primed, you're ready to work with mindfulness. So good luck and go and get some practice and teaching. Thank you very much for your attention.
Thank you. Chris, that's a fantastic talk. I think we'll move on. I'd like to present you with a small token of our thanks.